So this is PAD Awareness Month, and I guess you wonder why a foot doctor and a heart doctor might get together. Well, we're both interested in getting good blood supply to the legs and the feet, and podiatrists especially often see patients with vascular problems, and it's a mutual benefit to both of us. After we get blood flow to the feet, they can do their surgery or do their therapy, helping with neuropathies, helping with orthotics to help the patients get the right footwear. So it's a mutually beneficial relationship we have with each other, having mutual patients. A lot of other physicians, health care providers in the community also work with peripheral vascular disease. Vascular surgeons are very important, interventional radiologists. Some internists are interested in vascular medicine. Family practice doctors are interested in vascular medicine. So it's a whole group of physicians and healthcare providers in the community that work with peripheral arterial disease. So we're focused on PAD, especially of the legs and feet. Our podiatrists have surgical procedures, diagnostic procedures, physical therapy, specialized foot products for foot care. As interventional cardiologists, we're not only looking at the vasculature, but also looking at preventive care, lowering cholesterol, smoking cessation, diet, controlling diabetes. So we have a lot of overlap in what we do. But how many of you are aware of peripheral vascular disease or peripheral arterial disease or blockages in the legs? It's really, there's a lack of awareness with patients and with physicians about peripheral vascular disease. And that's why we're here today, try to educate and share knowledge we have. More commonly, people hear about coronary disease, heart attacks, and plaque and calcium buildup in the heart. But a lot of times we include, and my group is tired of me talking to them about peripheral vascular disease. Saying, guys, not only listen to the heart, but look at the feet, examine the whole vascular system, because I think it's very important for us to be able to not only look at the heart, but also the whole vascular system. We're all aware of cancer, breast and lung cancer. It's a lot more play than peripheral vascular disease. So our objectives tonight, we're going to talk about peripheral vascular disease, what causes it, why it matters, and who's at risk, what are the symptoms, how do we diagnose it, and what are some of the treatment options. Peripheral vascular disease is atherosclerosis of not just the legs, but that's what we're concentrating on tonight, but all the arterial system of the body. You can have blockages in the arteries going to the arm, blockages in the arteries going to the neck, blockages in the heart arteries. It's a systemic disease. There's about a 40 to 50% overlap between peripheral vascular disease of the legs and coronary disease, for example. So it's a big overlap. It's a systemic disease throughout the body. But there's gradual buildup of plaque in the arteries going to the legs that we can diagnose, and we can help patients symptomatically and sometimes save limbs by opening up blood vessels that supply the feet and legs. So as I mentioned, it's a systemic disease. There's carotid artery disease. 20% of strokes are caused by carotid disease. Yesterday I had a patient with severe high blood pressure and kidney insufficiency. Both his kidney arteries were severely blocked, and we were able to open both of those with stents. Abdominal aortic aneurysms are also part of peripheral vascular disease. And mesenteric blood vessels, blood vessels supplying the gut, sometimes they can be blocked, causing vascular problems as well. What are the causes of atherosclerosis? Here's a healthy artery with no blocks, and plaque begins early in life with fatty streaks within the blood vessel in childhood, even in the teens. And then gradually, as time goes on, as we all get older, there's more plaque buildup causing heart attacks, causing decreased blood flows to the legs, causing what we call claudication, or pain in the legs or discomfort in the legs caused by limited flow. As you walk, you can get cramps, you can get fatigue. It's just like heart disease though. Sometimes it's not always cramps. Just like with coronary disease, some people don't get chest discomfort or chest tightness, they become short of breath. So it's a big range of symptoms you can have, and a lot of people don't have symptoms at all. They say, well, it's my arthritis, or it's my neuropathy, or I'm just getting older. Well, it's not a natural part of getting older. A lot of times it's underlying peripheral vascular disease. And why does peripheral vascular disease matter? Well, it's very common. There are 8 to 12 million people in the United States that have peripheral vascular disease, peripheral arterial disease. But only about 20% of those, 2.5 million, are diagnosed. About half of those are treated, about a third with surgery, and 2/3 with endovascular techniques that myself and my colleagues perform. We can do better at diagnosing peripheral arterial disease, and with the help of our colleagues, podiatry colleagues, our internal medicine colleagues, vascular surgeons, we can all do better at diagnosing PAD. This is a interesting study. It did an awareness study. About 2,500 people were surveyed, about Americans greater than 50 years of age. How many people were aware of what a PAD was? Only 26%. Now, how many people have PAD? 8 to 12 million, as we discussed just a while ago. But cystic fibrosis, they're more aware of cystic fibrosis, but only 30,000 people in America have cystic fibrosis. Lou Gehrig's disease, a lot of people knew about that, but only 20,000 people, or Americans, have Lou Gehrig's disease. Multiple sclerosis, more common disorder, 300,000, but still, as opposed to the prevalence and number of people that have peripheral vascular disease, the awareness is very low. Physicians are guilty too. I mean, as I've told you, I advocate within my group for people to look for peripheral arterial disease. Have people take off their socks, look at their feet, ask about symptoms in the legs. I think it's very important for us to be more comprehensive in how we look at our patients. If you look at the incidence of cancer, it's about 11 million people in the United States. Peripheral arterial disease is close behind. Is this a serious condition? Sure is. It's especially when it gets to the end stage. We'll talk about how when people get to critical limb ischemia, that's really a serious problem. And if you have to have an amputation, that's really a serious problem. It's a bad prognostic sign, because it's a marker. By the time it gets that severe, causing bad problems in your legs, it's a marker for severe systemic disease. A lot of people have a heart attack or other problems. So it's important to identify it, because as we manage the particular disease in the limb, we're also looking at managing other risk factors and preventing its progression elsewhere in the body. So this is what I mentioned, critical limb ischemia. It's a marker for death. If within 3 months, 9% of the people present with a severe gangrene or ischemia die. 1% have strokes, 1% have myocardial infarctions, and 12% have amputations. 1-year mortality is 21%. 2-year mortality is 30%. So a serious problem. It's a marker for severe systemic disease. And if we look at 5-year mortality of PAD compared to different types of cancer, it's right in the middle. We always think of cancer being a severe problem. PAD is also a severe problem. As I mentioned, this is a systemic disease. Peripheral arterial disease may be the first warning sign of systemic atherosclerosis, affecting the heart and brain, sometimes the gut. So it's an important to be aware of it, important to treat it. High risk of heart attack because of that big overlap, again, of peripheral arterial disease and systemic vascular disease. And 2 to 6% times the risk of death due to coronary events. Risk of stroke is increased by 40%. And even if you're asymptomatic, you have a higher mortality rate. If you have severe peripheral vascular disease like the clinical limb ischemia, this is what we just talked about in an earlier slide, it can be as high as 20 to 25%. And if after you have an amputation, your mobility's limited, you can have other problems occur. That's why we really want to try to preserve limbs and keep people from having amputations if we can. As the severity of peripheral vascular disease increases, the rate of amputation goes up, and comprehensive foot care program is really important, and it can reduce amputations by 40 to 85%. That's where our podiatry colleagues can really help out. And less than half of the amputees regain their ability to walk. 15% require amputation of the other limb. Again, a systemic disease. One limb, it's amazing how symmetrical it is. When you see a block in one leg, the other leg will have a very similar block oftentimes. Not always, but many times. So what are the risk factors? We all know them. I have a patient in the hospital now. He's still smoking a pack a day, and he's got just such severe peripheral vascular disease, and he just can't stop. It really is very sad to see that. That's probably number one. Smoking cessation as a reversing and preventing further peripheral arterial disease. Diabetes, also a high risk factor. High cholesterol, hypertension, obesity, physical inactivity. Walking helps. A lot of times when people have blocks, we don't have to do anything because the body develops collaterals. And if you go on a gradual walking program, it's been shown in several large studies that you improve your symptoms just by increasing activities, not having someone do surgery on you, not having balloons or stents. So oftentimes, if the symptoms aren't bad, we advocate walking, changing lifestyle, not necessarily doing procedures. Of course, we can't do anything about our age, or we can't choose our parents more carefully. Symptoms. 2/3 of people don't have many symptoms, or they have vague symptoms. Vague leg fatigue attributed to, oh, it's my arthritis, or it's a neuropathy. Well, and depending on the level of the blockage, if you have symptoms in your buttocks when you walk, it's probably up high. At your belly button, your aorta divides into the iliac arteries. If you have symptoms in the buttocks when you walk, it's probably in an iliac artery. If it's further down in the thigh, again, it's higher up. And the most common disease we see is in the superficial femoral arteries in the thighs. And that usually causes your calves to cramp up and is relieved when you rest. It's just like you put stress on your calf muscles. It's not getting as much blood supply as you walk. And so when you rest, it feels better. In fact, when we tell people to do a walking program, we ask them, stop. When you have discomfort, rest, walk some more. That helps build up those collaterals. Now, we also want to be very aware of leg pain that doesn't go away, or the leg pain that occurs at night, and you can dangle your legs over the side of the bed, and the symptoms get a little better. It's one of Newton's laws, gravity. Gravity helps get blood supply down to the feet. You can dangle your legs over the side of the bed and help the symptoms sometimes when it's very severe. And also looking at foot or toe wounds that won't heal. And also, obviously, when you have gangrene of a toe or a foot, that's a serious problem. So claudication at rest. This is a picture of someone's severe gangrene of their toes. And then a wet gangrene. And then what we want to avoid, if at all possible, is preventing this. So pay attention to your symptoms. Look at your feet. Have a thorough examination by your physician. There's simple tests like doing an ankle brachial index. You compare the pressure in your arm, your brachial artery, and your ankle, It should be the same. It's a ratio. It should be 1. So that's an easy test to do. It doesn't take long, and it's a good screening test. We can do a Doppler test all the way down the leg. We can look at the blood vessels in the leg and also look for high velocities, just like a garden hose. When the garden hose gets pinched, the flow is very fast. And so we can pick up that extra velocity indicating a severe block. We can use a CT scanner to do a CT angiogram. We can do magnetic resonance angiography. We can do angiography that's an invasive procedure like doing a heart cath. And here's how we look at the ABI, or ankle brachial index. It's a ratio of the pressure in your arms compared to your ankles. The normal range is 1 to 1.4. And some of the diabetics, and you notice there's an upper limit. Some people have diabetes and have very calcified arteries will have a high ABI, and that's not normal either. It means your arteries have become calcified and very stiff, and the ABI is not very reliable. So that's abnormal. We look at a high ABI as being a bad thing as well. And then the borderline levels here, 0.9 and less than 0.9. And usually when you get to less than 0.4 for an ABI, that's pain and ulceration. And as I mentioned, above 1.4 is bad. That means you've got a calcified artery that may have severe blocks. And these are the folks we need to screen. If you're 50 years or older and you smoke or have diabetes, you probably should get an ABI. If you're 65 years of older, you should be screened and look for peripheral vascular disease. So what's our treatment? Good news, we have some good treatments. Not always do we do procedures. We try to, as I mentioned earlier, a walking program, certain medicines we can use, help. Also, having a healthy lifestyle helps and can reverse some of this disease. So physical activities, diet, smoking cessation, medicines we can use aspirin. Plavix is another blood thinner we can use. Cilostazol or Plital also helps with circulation. And our traditional medicines for blood pressure, cholesterol, and diabetes are also helpful. And with non-surgical approaches, these endovascular interventions, which I and some of my colleagues do, we use balloons. We have newer balloons that are drug-coated and help prevent the reblockage of these arteries once we open them up. We have stents that are plain stents and some that are drug-coated, also inhibiting the reblockage of the arteries. And we also have atherectomy devices. We have a laser device we use that vaporizes plaque. We have a shaver that shaves out the plaque. We have a little burr that burrs out the real calcified arteries. And of course, there's surgery for patients we can open with these endovascular techniques where they bypass the blockage with a vein graft or a synthetic graft they use. So this is what the blocked artery looks like. We put a balloon inside and can spread the plaque apart and give better blood flow to the limb. We have stents that act like scaffolding. We're using less and less stents now. We try not to use metal inside the artery if we don't have to. And some of these drug-coated balloons are making it so we don't have to use the stents as much as we used to.
What's the balloon made out of?
Oh, it's just a plastics material. It's just, and you have this, you have a mixture of saline and contrast. We can see the balloon come up as we look at it under fluoroscopy, and so it spreads the tissue apart. And this is the atherectomy tool we use a lot. It has a little cutter, and it packs the plaque down into this nose cone, and we remove it and take it out of the body. We'll show you an example of a patient we use this on, and then the laser just kind of vaporizes the plaque. So this is a case of patient 53 years old, diabetes, high cholesterol, smoking, all the bad risk factors. She had severe leg pains. And she had screening tests, the ABIs, that were very abnormal. And so she ended up getting an angiogram. All right, this is your belly button's about right here. This is up in the abdomen. This is where at the bottom of the leg. This is the iliac artery is up high. Remember, I mentioned earlier, if you have blocks up here, you'll have pain in your buttocks because it's up high in the abdomen. Down here, we're at the groin area. Let's see, and then this is a picture of our thigh artery, and there are two arteries that come off down here. There's a deep femoral artery and a superficial femoral artery. We also call that just the femoral artery now. And this deep femoral artery is supplying collaterals to an artery that's blocked here. There should be another artery coming down. It's totally blocked. That red line shows where the blood vessel should be. There's not a blood vessel there. And this is at the knee level. You kind of see the kneecap right there. So these are the little collaterals we talked about that you help develop with a walking program. These collaterals can do a pretty good job, but it's better if you're going to Charlottesville, I'd rather go I-64 than all the little country roads. So back here. So but they work, and with walking, you improve and can get some relief there. So yeah, so we want I-64 open there. And then this is below the knee. There are 3 blood vessels below the knee. There's a perineal artery, anterior tibial and posterior tibial artery here. So this is where we're working in this thigh artery right here. This artery was occluded right here. This is the deep femoral artery over to the left. And this artery was totally blocked from here, right there where it shows it being totally blocked. So we went in, we used a small balloon to open up the artery, get a little pilot channel, and then we used that atherectomy device. And this is all the stuff, everybody goes, yuck, all the stuff we got out of the leg artery. After we did the atherectomy, you can see this artery that wasn't there before. Now we're starting to see it. And we smoothed it out with a drug-coated balloon at the end. And now there's blood flow all the way down to the knee. This artery was occluded. That little collateral was coming in right there before. We didn't have the straight I-64 highway open. Now it's open. It's much better blood flow to the leg and the foot. And so that's just an example of what we can do. This is a patient of Dr. Kumar's. The patient is 72 years old. She had a non-healing wound on her right foot for 6 months. She was evaluated vascular surgery, and she was scheduled for the below the knee amputation. She's already had one below the knee amputation on the left side. She's had a previous leg bypass. What do? There's no more very good surgical options. So fortunately, Dr. Kumar came along and said, okay, here we are. We think we'll try to get through the total block here. And here's a severe wound on the foot. And so here are the angiograms. Now this is the old bypass. The bypass was fine. Only problem it was a bridge to nowhere. Here's the bypass coming down. Here's the blood vessel. Nice bypass. Problem is it went to nowhere because there's another severe block in the popliteal artery that's right at the knee joint. And so he was able to get a wire through this. Then I'm not sure if he did an atherectomy on this, but also did a balloon. And so there's a total occluded area, but it reconstitutes. Again, these little collaterals save the leg. And then this is after the balloon. Got a wire through it, got a balloon open, got it open. And this is before, and this is after. It healed up, and saved this lady's leg. And we talked a while ago about how bad it is to have an amputation. So PAD is life-threatening. It can be managed or even reversed with good care. So this is just a kind of summary of foot care and PAD. There's an endocrinologist that said, a guy had a great quote, look at your feet as much as you look at your face. Every day we go and look at our face and we shave, but we don't look at our feet, especially if you're a diabetic. Look at your feet as much as you look at your face. I think that's a great quote. So daily look at your feet. Good cleansing, good moisturizing, appropriate footwear. Promptly address any kind of little ulcers or irritated areas. Podiatric care. I mean, just don't go to the mall and get your nails clipped. And who knows what kind of infection you can get. I mean, go to his place. They have great pedicure places there. The equipment's very sterile, and they offer all that stuff. So do it the safest way you can, especially when you have diabetes or you have other risk factors for peripheral vascular disease. So proper foot care is really important. Dr. Mountain's group offers annual foot exams, especially for diabetic patients. It's a great service. And so I'm constantly sending my patients to the podiatrist so they can get really close observation of their foot care and have good foot care. So things to remember. Most common symptoms of PAD are cramping, pain, or tiredness in the leg or hip muscles while walking or climbing. Typically goes away when you stop. Many people with PAD never have any symptoms. So if you have risk factors, you should be thinking about it, maybe get screened. Many people mistake the symptoms of PAD for something else. Oh, it's my arthritis, it's my age, it's neuropathy, it's what I ate yesterday. So it often goes diagnosed by healthcare professionals. So be aware of it yourself and ask if you have risk factors, ask to be screened. And it's an important marker for systemic disease. It can give you more risk for heart attack and stroke. If you leave it untreated, it can lead to gangrene or amputation with its attendant problems of bad lifestyle and more serious problems. So important to learn the facts about PAD. As with any disease process or anything, the more you understand, the more you'll be able to help your healthcare professional make an early diagnosis and treat you. So we're trying to do this program to be so you can join us in being proactive and early identification and treatment and referral to have an endovascular evaluation to see if there's some role for these procedures we talked about. Like I say, a lot of patients I don't treat with procedures, not when we can get by with less. And aggressive wound care, if there are any wounds in the feet. And our group has several of us that are boarded and have training in endovascular therapies. And we're West End, this office here, Hanover, and Prince George. We have all the non-invasive testing. We have a screening program called Vascular View. We can do all the different interventions we've discussed. And thank you very much.